We are really trying to take our cues from veterans living with chronic pain. We don't want to decide what's important for you. We want you to tell us what's important. What I've put here is a study that we published back in 2018. Basically, it was an effort to talk to 1,500 individuals in Canada living with chronic pain or their caretakers to determine research priorities. And you can see some of the main themes in the blue circles below, not overly surprising. And we're currently engaged in efforts to speak directly to veterans living with chronic pain. And we anticipate enriching our research priorities with that information in the next 3 to 4 months. But in basic, some of the themes that come out, and I've seen them come across in the chats during this talk, how do we prevent acute pain from becoming chronic? And how do we deal with chronic pain to prevent it from flaring up or exacerbating? The idea, for example, that we spend $60 billion a year on all kinds of treatment to manage chronic pain, such as pharmacotherapy, etc. What about the idea about providing people with access to a gym membership so that they can work on keeping themselves in a state where their pain is less likely to impact them? In terms of providing optimal management of chronic pain, we often hear stories where individuals have gone to a dozen different practitioners and they've received a dozen different recommendations for different therapies. Well, what works? What doesn't work? How well does it work? In whom is it more likely to work? These are important questions we still need to answer. And in terms of measuring patient-important outcomes, people living with pain are more than just their pain. I saw across the chat, many people have to work with their pain. So they're going to be interested to know if they engage in a therapy, if they take their time, what is the likelihood it's going to help them stay at work or improve their sleep or improve their quality of life? We need to measure broadly so that we can really provide individuals with comprehensive information on all the domains that therapy is likely to help them improve in. One area that we have consistently heard questions about is the potential role of medical cannabis in the management of chronic pain, also in some other forms of complaints as well, but predominantly chronic pain. And here you can see the results from tracking that Health Canada does, looking at the number of individuals in Canada that are authorized to use medical cannabis. And you can see from 2015 up till 2018, a 3-year span, that number has increased dramatically from 24,000 to close to 350,000. Those numbers have also gone up. You can see that amongst Canadian veterans, there's a similar trend. In 2008, there was a grand total of 5 veterans that were being reimbursed for medical cannabis. At the end of 2018, that number was north of 10,000. In terms of the actual financial spend on that, you can see that in 2018, Ottawa paid $75 million for veterans cannabis. 2019, that had gone up to $100 million. And when I was interviewed for this article, the point that I made is that cannabis has become available for therapeutic use not because we have a strong evidence base to really give us good information about the anticipated benefit and harms, but more through a series of legal challenges and on compassionate grounds. So we need to do the work required to understand what is the role of cannabis and who is it likely to be helpful for and who is it maybe not likely to be a good option for. One of the challenges we have in the research community is getting the findings out into practice. I saw one of the points in the chat window asking how well we get this information out to veterans and their care providers to help. We know that on average, it takes about 18 years before research findings are translated into practice. And that is far too inefficient for anyone to be comfortable with. In recognition of this, the British Medical Journal has initiated a product called Rapid Recommendations, or Rapid Recs. And they take areas of particular concern or where practice is likely to be changed by emerging evidence, and they instigate a very rapid process to do a synthesis of all evidence relevant to that area and to put out a focused clinical practice guideline. And Just to give you an example of how something like this would work, I'm just going to show you a previous one that we did. There's a type of device called a low-intensity pulsed ultrasound bone stimulators. And these are popular devices for healing fractures. They're used by about 50% of all trauma surgeons in Canada. Annual market in North America is around $500 million for selling these devices. But the question is, if only half of surgeons are using them, why aren't the other half? Or maybe no one should be using them. Everyone can't be right. So we noticed there was some problems with the literature. We conducted a large randomized study, and the findings helped provide some clarity around this issue, and that sparked off one of these rapid recommendations. So we then looked at all of the evidence relevant to this question: how well do bone stimulators work for fracture healing? And when we compiled all this evidence, we found that, unfortunately, the evidence supporting their use was only from low quality studies that had a lot of problems with them. And the higher quality evidence all consistently found that they actually didn't work. And so this information was then provided to a panel of experts and patient representatives. And when they reviewed all this evidence, they were very quickly able to come to a strong recommendation against the use of these bone stimulators for managing fracture healing. And this is the sort of infographic of what a rapid recommendation would look like. And the software we use to derive these is able to be inserted directly into the electronic medical records of clinics. And so if a patient comes in with a question about a certain area, this kind of recommendation, this information can be pulled up at the point of care and become part of the discussion when patients are deciding if they want to pursue a therapy or not. And we're currently completing one of these rapid recommendations on cannabis and chronic pain, which we anticipate will be out later this year. We also have the opportunity to learn from data that has already been collected or is currently being collected. There's a lot of observational data out there. One source is from the Institute for Clinical and Evaluative Sciences in Ontario. This is a government organization that tracks all healthcare utilization in the province, all medications, all hospital administrations. And they do have an identifier that allows us to pick out which patients are veterans. So we are in the process of designing studies we can use to better understand the kinds of care that veterans living with chronic pain receive, how quickly they get that care, and what the impact of that is. There's also a partnership between Veterans Affairs Canada and Statistics Canada to administer something called the Life After Service Study. And this is administered to veterans across Canada, a representative sample once every 3 years. And it gives us a sense about how well they're doing. What is their health status? How many are dealing with chronic pain? What kind of services are they receiving? So again, we have the opportunity to learn from this kind of information. We're also talking to Veterans Affairs Canada about the possibility of approaching military personnel upon release to join a prospective study to see if they'd be interested in providing information, both those that are discharged with chronic pain and those without, to really understand what is their journey like, how well do they do over time. For those that are released without chronic pain, who goes on to develop chronic pain? Could we do something with that learning to help prevent chronic pain from emerging in some cases? And finally, VAC administrative data. We have heard concerns, and I've seen some of them in the chat window, about there being delays in communication, challenges engaging with civilian healthcare services, perhaps lengthy period of time from submission of a claim to VAC and when that claim is approved. We could look at these issues and determine how widespread they are, if they've been changing over time, and look to explore and identify targets to maybe improve the situation where warranted. And to the point about measuring all sorts of important domains amongst individuals living with chronic pain, there has been good work conducted in collaboration between veterans and also Veterans Affairs Canada to identify 7 domains of well-being that were seen as important to understand the overall wellness of an individual. And of course, one of those is health. Health is obviously critical to how we do, but there are other things as well. And you can see here life skills and preparedness, financial health, social integration, employment or other meaningful activity. These are all important things to consider when trying to understand how well someone is doing. And we need to understand how we can best measure these different constructs. So we're also engaging in a series of studies to identify how well or how best to measure these different areas of well-being, so we can start to put those out into practice and collect information to understand exactly how well veterans are doing in these areas. So in summary, if we are going to conduct and produce research that will actually be helpful for veterans living with chronic pain, we need to do a couple of things. We have to make sure that the research is accountable to the stakeholders that it's supposed to help. So we need veterans to help us set those research priorities. And we do have a veterans advisory group that has been formed. We are surveying veterans. I encourage anyone who would like to participate in the process to reach out. We do want to hear your views. Studies have to target practical issues. We don't want to do pie in the sky research. We want to know what are the issues that are affecting veterans right now, and how can we do research to provide answers that are likely to be helpful with practical issues. And finally, we have to do more than just publish a paper in a journal. We have to find a way to get research integrated into practice, and we have to measure the impact of doing so. If it's not improving the lives of veterans, then the research hasn't been helpful. So we have to be accountable not only to pick topics that are important, not only to pursue research well, but to take stewardship of moving it into practice and measuring the impact. And thank you for your time.